Good morning, dear students. I am Abida, Associate Professor, Department of Pharmaceutical Chemistry. Today, we can discuss the session Anti-Diabetic Agent as a part of Medicinal Chemistry II in 5th semester B Pharm. So, the subject Medicinal Chemistry II, which deals with main course objective as to understand the chemistry of drugs with respect to their pharmacological activity, understand the drug metabolic pathway, adverse effects, and therapeutic value of drugs. Know the structure activity relationship of different class of drug. Write the chemical synthesis of some of the selected drug. These are the main 4 course objectives related to the medicinal chemistry 2 subject. Here, today's session, the main learning objective include an overview of diabetes mellitus, the classification of anti-diabetic therapy, insulin types and its preparation, oral hypoglycemic agent, their chemical structure, and mechanism of action. These are the main learning objective for today's session. That's an overview on diabetes mellitus and its classification, and the first class of drug for anti-diabetic agent, that is insulin. Then comes to the oral hypoglycemic agent and their structure and mechanism of action. Then diabetes mellitus. What do you mean by diabetes mellitus? What's the different type of diabetes mellitus? Diabetes mellitus is mainly known for a high level of glucose in blood level. The elevated blood glucose level causes a condition called hyperglycemic condition. This will result in diabetes mellitus. And it can be characterized into two types, type 1 and type 2, mainly two types, and the other one is gestational diabetes. Its prevalence exceeds 460 million worldwide. The main reason for this diabetes mellitus are impaired insulin secretion, insulin resistance, and hepatic glucose overproduction drive chronic hyperglycemic. Yeah. Then the main target for diabetes mellitus, that is hemoglobin. In this condition, glycated hemoglobin is a blood test that shows the average blood glucose level over the past 2 to 3 months. The treatment goal in most patients with diabetes is to keep this hemoglobin below 7% to achieve good glycemic control and prevent complication. Then in the case of hypoglycemia, it means abnormally low blood glucose levels. Anti-diabetic therapy should control glucose without causing dangerous drops in blood sugar, which can lead to dizziness, confusion, or fainting. Then next case is the case of weight. Many patients with type 2 diabetes mellitus are overweight or obese. Treatment should help to maintain or reduce body weight, since weight loss improves insulin sensitivity and glucose control. And in the case of cardiovascular risk factor, diabetes increases the risk of heart diseases such as coronary artery disease and stroke. Therapy should reduce blood pressure, cholesterol, and heart disease risk. And finally, in the case of renal risk, long-term diabetes can damage the kidney and it results in diabetic nephropathy. Treatment strategies should protect kidney function and prevent progression to kidney failure. And as a control or a solution to these cases, we can use the different class of therapies like insulin, oral hypoglycemic agents, and non-insulin injectables. Each act on distinct metabolic pathways. So the classification of anti-diabetic therapy, it is mainly focusing on three types. First one is insulin preparation, second one is oral hypoglycemic agent, third one is non-insulin injectables. In the case of insulin preparations, rapid, short, intermediate and long-acting formulations covering basal bolus regimens are included. In the case of oral hypoglycemic agent, diverse mechanisms including sulfonylurea, biguanides, thiazolidinedione derivative, DPP4 and SGLT2 inhibitors have been used. In the case of non-insulin injectables, GLP-1 receptor agonist and amylin analogs administered subcutaneously. So these are the main three therapy methods in the case of anti-diabetic agents. Then when we are coming to the first and foremost treatment, that is insulin. And insulin, which as we know that insulin, which is an hormone released by beta cells of islets of Langerhans of pancreas, and the body will produce insulin to have a control over the blood glucose level. And when there is an impairment in this control, we are providing it externally. So when we are providing it externally, which are the different preparations include in that? First one is rapid acting. The important brands are Lispro, Aspar, Glulicin, and these can shows an onset within 10 to 15 minutes, and the peak will be 1 to 2 hours, duration 3 to 5 hours, suited for mealtime coverage. And in the case of short acting or regular human insulin, onset will be 30 minutes, the peak time 2 to 3 hours, and the duration will be 5 to 8 hours, and these are the classic basal bolus component. Then next classification, which is known as intermediate acting or NPH, where NPH is the neutral protamine hedged on. Its onset is 2 to 4 hours and the peak is 4 to 12 hours, duration up to 18 hours, often combined with short acting insulin. Then in the case of long acting, the brands are Glargine, Detimir, Degludec. These have flat profile. Minimal peak duration will be 24 to 42 hours, which provide basal insulin coverage. So these are the main four types of insulin and its preparations. It is very important as a concept in the aspect of question. Usually the question will be asking insulin, its type and preparation. So you can include the four different types of insulin preparation. Then when we are coming to the oral hypoglycemic agent, in the case of insulin, it is mainly prescribed for type 1 diabetes mellitus, where it is an autoimmune condition. And when we are coming to the type 2 diabetes mellitus, it will be mainly due to the lifestyle and our day-to-day activities, all will be affecting our type 2 diabetes mellitus. And in such cases, we are mainly prescribing oral hypoglycemic agent. And the oral hypoglycemic agent mainly focus on the four different classification, and additionally we can see 3 to 5 classification, but the main four classification which focus on oral hypoglycemic agent are sulfonylurea, biguanides, meglitinides and thiazolidinedione derivatives. And the others include alpha glucosidase inhibitors, DPP4 inhibitors, then SGLT inhibitors. Like these inhibitors can be used for oral hypoglycemic action, but the most common and important class belongs the other four, that is sulfonylurea, biguanides, meglitinide and thiazolidinedione. And in the case of sulfonylurea, this is the first and foremost classification, comes under oral hypoglycemic agent. In that, the first one is first generation sulfonylurea, example tolbutamide and chlorpropamide. And in the case of second generation, glibenclamide, glipizide, glycoside, glimepiride, etc. can be used as a second generation sulfonylurea. And the most important classification in the case of oral hypoglycemic agents are sulfonylurea, and the first generation drugs like tolbutamide, chlorpropamide are now the chances of using these drugs are limited, and the advancement and the resistance for these drugs result in the path for second generation development of second generation class of sulfonylurea. And now the prescription level, when we are seeing the prescription level, we can see mostly prescribed class of sulfonylurea belongs to the second generation. Then similar to the sulfonylurea, next class, that is meglitinide class. These sulfonylurea and meglitinides, they will enhance the sensitivity of insulin receptors for the action of insulin. So meglitinide, which again shows a similar mechanism with the sulfonylurea, and the example is repaglinide and natiglinide. Then next class, important class, is biguanides. Biguanides, the most important drug is metformin, fenformin, etc. And this biguanides is again next mostly prescribed classification of drugs, that is biguanides. Then next and the fourth classification, that is thiazolidine derivatives, or their other name is glitazones. Example, rosiglitazones and pioglitazones. So these are the four important types of classification in the case of oral hypoglycemic agent. First one sulfonylurea, second one biguanides, third one meglitinides, and fourth one thiazolidine. Then next class, which comes as alpha glucosidase inhibitors, example acarbose, miglitol, viglibose, etc. Then when we are coming to the modern aspect, or in the present studies, the most important type of oral hypoglycemic drugs which comes are DPP4 inhibitors like sitagliptin and SGLT2 inhibitors like empagliflozin. Were already existing sulfonylurea drugs like glibenclamide, which stimulate the pancreatic beta cell insulin, which releases ATP sensitive potassium channel blockade. Then the biguanides like metformin, which reduce the hepatic gluconeogenesis and improve the peripheral insulin sensitivity through AMP dependent kinase activation. Then in the case of thiazolidine derivatives like pioglitazone, they activate PPAR gamma receptors to enhance the adipose tissue insulin sensitivity and modulate the inflammation. And when we are coming to the modern drugs like DPP4 inhibitors like sitagliptin, it prolongs the endogenous GLP-1 activity by inhibiting dipeptidyl peptidase 4 degradation. And in the case of sodium glucose cotransporter 2 inhibitors like empagliflozin, they block the renal glucose reabsorption, promoting glucoseuria and modest weight loss. Then when we are coming to the sulfonylurea, which is the most important class, and it is known as insulinotropic agent and widely used oral hypoglycemic agent, and this is acidic in nature. And you can see their structure, which is having a sulfonamide moiety with it, where R1 R2 substitution can see. This R1 and R2 varies, accordingly the drugs also varies. So this is a brief structure on how the first and second generation varies with R1 and R2 substitution. In the case of chlorpropamide, with R1 you can see Cl, and R2 you can see a propane moiety. With the tolbutamide, R1 is CH3, whereas R2 is a pentane moiety. And in the case of tolazamide, R1 is CH3 or methyl group, and R2 is a pyridine moiety. When we are coming to the second generation, we can see both R1 and R2 with the aromatic ring substitutions are mostly done in the case of second generation drugs. Then next one is biguanidins. In the case of biguanidins, you can see guanidin residue along with the drugs like fenformin, metformin, etc. Then thiazolidine derivatives, you can see how it varies with the R substitution, pioglitazone and rosiglitazone. Then this is the meglitinide, example natiglinide structure. Then in the case of alpha glucosidase inhibitors, we have a common drug that is acarbose, which is an oligosaccharide, and voglibose is another sugar moiety also attached with the drug. Miglitol is also comes under alpha glucosidase inhibitors. So these are the important class of drugs which comes under an oral hypoglycemic agent and their structures. Then the main mechanism of action included in the case of oral hypoglycemic drugs. The first one is sulfonylurea. Sulfonylurea, when bind over the sulfonylurea receptor, this will result in K plus channel or potassium channel closing, and that will favor the depolarization state. Depolarization involves the entry of calcium that will result in exocytosis where the insulin will be released from its vesicle, and this will activate the response of insulin, and the insulin related responses will be characterized as a result of the binding of sulfonylurea to its receptor. Then when we are coming to the biguanides like metformin, the mechanism is mainly focusing on metformin that activate the AMP dependent kinase, and this will result in decreasing the blood glucose level, where the hepatic gluconeogenesis is also inhibited in this process. As a result, due to the action of metformin or biguanides, the blood glucose level will decrease and that will result in a decreased intestinal glucose absorption and increased peripheral glucose uptake in the case of skeletal muscle. So these three are related in the case of biguanides, and the most two important classes, sulfonylurea and biguanides, which mechanism we have specified in this is important as a in the concept of question also. Biguanides and sulfonylurea mechanisms are widely asked question. And when we are coming to the clinical outcome and evidence, which are not at all related to our medicinal chemistry aspect, we can see a reduction in the hemoglobin level, weight change, risk of hypoglycemia, cardiovascular benefit can be, then renal protection. These are the clinical outcome related to anti-diabetic agent. Then as a part of our medicinal chemistry 2 curriculum, we can see the learning of outcomes from the session, that is the classification of anti-diabetic agent. Mainly for type 1 it is insulin and its preparation, and type 2 it is oral hypoglycemic agent, and their different classes like sulfonylurea, meglitinides, then biguanides, thiazolidines, and alpha glucosidase inhibitors. Then when we are coming to the mechanism of action part, sulfonylurea and biguanides mechanism we have discussed. Along with that, the classification and the important drug structures are also included in the content. So the learning outcome with a Bloom level of K1 and K2 will be included in this session, and hope that you will be following the outcome, or within a few minutes of revision, you can just remember the drug name and classification, and you can have a brief discussion on the mechanism of action in the case of sulfonylurea and biguanides. So that's all. Thank you.